This episode of Q Point Podcast is pre-recorded, produced and sponsored by Keri Quirk, broker at Next Home Experience.
Different views.
I know your story.
From different cues.
Incredible job.
He's David Quirk.
You brought it up.
And she's Corenna Quirk.
Imagine.
This is
Q Point.
Now joining us in studio is Keri Kapaldo, RN and SAFE Program Coordinator at St. Joseph Hospital. Welcome to the program.
Thank you.
Yes, thank you for coming in.
Thanks for having me. It was a great invite. I was excited.
For listeners who may be hearing about this for the first time, what exactly is the SAFE program at St. Joseph Hospital?
We are a dedicated department that's adjacent to the emergency room. That's how I explain that. And we're a group of nurses who have specialized training to take care of people who have been impacted by violence. That's the broadest definition I can come up with for that. The nurses are called SAFEs, so we call the department the SAFE program. What is a SAFE? That's always my first question that I get. It technically stands for Sexual Assault Forensic Examiner. The root of our education and training when this first started decades ago was to take care of people who presented to hospitals for sexual assault. It was a way to bridge the gap between healthcare and law enforcement. And there's specialized training to take care of somebody and how to collect evidence off of a body and things like that. Fast forward 2 decades plus later, and we've morphed this into something that's really medically centered, patient-centered, trauma-informed. And our program specifically takes care of anyone impacted by violence, domestic violence, child abuse, elder abuse, and anything that falls in between. All genders, doesn't matter who the offender is or who the victim is, we take care of them.
How does someone actually access a SAFE nurse?
That might look different depending on what state you live in, but in Maine, typically SAFE nurses are accessible through emergency departments. Not all hospitals in our state have SAFE nurses or nurses who have taken training, but we're working on that. I do sit on the State of Maine SAFE Advisory Board, and that's one of our goals, to get SAFE nurses everywhere and accessible to everyone. We're making progress. There's quite a few hospitals in our state that have access to SAFE nurses. Something that makes us a little bit unique is that we have this dedicated department, and we're guaranteeing a SAFE nurse 24 hours a day, 7 days a week. So we're there most days, 9 to 9, and then on call, off hours. Sometimes we'll do on call for holidays or low volume things, but we're there and we're available.
So they come through the ER. When they arrive, I presume they're triaged. And then does a SAFE nurse show up, or is this an after appointment?
That depends on which hospital you end up in. But our hospital, our nurses, if we're there, will either be the one that triages the patient or will be responding immediately because they're staffed and there. All of our nurses are dual ER nurses, and we assume the total care of the patient along with the emergency room physician. So you're not getting a triage, an ER nurse, a doctor, and then another person coming in. We do that to mitigate, obviously, you having to tell what happened more than once, and it also lessens the amount of people who know the details of something so incredibly personal. If we're not there, or maybe we're with another patient, they will go through normal triage process. But we have a policy at St. Joe's where they don't go back to the waiting room. So if they check in and they say they need to see a SAFE nurse, or they're there because they've been assaulted, they get priority triage because they're technically a trauma patient. And then we do priority waiting room. So we have a private waiting room out back that we can take them to so they're not exposed to a lot of other people while we're waiting to put them into an ED room, or they go right back because they are a trauma patient. So they get access to a SAFE nurse pretty quickly. If we're on call, our response time is 70 minutes. That's from they check in, they get triaged, we immediately get called, and the nurse will be there within an hour.
Say someone was assaulted 2 days ago and it wasn't immediate, and then they go to the ER, or maybe they've made a police report. Are you still able to help them?
Absolutely. That's super common, actually. The nature of the way we process trauma can look a little bit different for everyone. And sometimes it takes a little bit to realize what happened or to process your options. Sometimes it's not always safe. And we always say that the patient, victim, survivor, depending on how you're working with them, knows their situation best. And maybe it's not safe for them to come right over. We will see people usually a couple days after. That first 48 hours is usually the time frame when we'll see people come through. But depending on the nature of their injuries, the type of assault, we can see people 7 days out for sexual assault. And we can see them certainly after. We will consult with them and get them connected to resources. But the options for evidence collection and things like that goes down the further you go out for sexual assault. Domestic violence depends on the injuries and the nature of the assault. and we'll connect with them, consult, and meet them wherever they're at, whatever they need, try to connect them with whatever we can in that moment.
Speaking of domestic assault, we know it's very common for them to then not make a police report and disappear, but then maybe they'll return at a later date. Do you follow up with them after, or what's that process?
We only follow up if the patient wants us to. Of course, there's a lot of safety issues if we blindly called a patient for follow-up. So we always want to make sure that the patient wants us to, that the phone number is okay to call, that it's safe to leave a message or not, things of that nature. A lot of times the follow-up looks like them calling us when they can choose that environment and when and how to call us. There is a certain mechanism of injury, strangulation, that we do encourage follow-up, including coming back to us for re-examination, but we give them, again, options. So our preference is they come back in a couple of days. If they can't do that, then we try to do phone follow-up and going through their injuries and signs and symptoms and making sure that things are getting better. And then if not, we leave it up to them to be able to call us. Again, just connecting with them and what their situation and what they feel is best.
So we know that you're an RN, but you also had to take special training to become a safe nurse?
Yes. This varies state to state again, so you're going to find that that's a common message. But the state of Maine has a actual safe program director, and they oversee the training and education of safe nurses in the state. So we're doing a lot better than some other places. A couple of times a year, they offer an adult adolescent course. So that means it's a sexual assault forensic examiner course, 40 hours, intense training on everything you can imagine on how to care for an adult or adolescent victim of sexual violence. And they also have a simulation day. So we have live models that will simulate being a patient, a victim of sexual assault, and taking care of them, doing a mock exam. And we're all preceptors and help, train the younger folks up and ready to get them out. Just that alone is 48 hours. On top of that, to get credentialed by the state of Maine, you have to prove that you have been able to examine the body properly. You have to watch a couple of exams get done by an actual safe nurse. You have to be precepted by a safe nurse performing exams. You have to meet with people in the community that work with survivors. So law enforcement, district attorneys, advocates. You have to connect with your resources. You have to start to build those relationships because we can't do this by ourselves. And you have to learn how to go to court, do a little practice and testimony because we are a piece of that puzzle sometimes. So there's a lot of extra steps. You have a year to complete it once you go through training. And that's just for adults and adolescents. So there's an additional training that has additional classroom time, another 48-hour course with more clinical time and things of that nature for pediatrics as well. And that's just for our state. You have to do ongoing education all the time.
So I understand the training, but what about training for you after you see a trauma case and you go home at night? How do you handle that?
We do cover vicarious trauma in the course and attend quite a bit of stuff throughout our time. I've been a safe nurse for almost 11 years, and I have had a lot of vicarious trauma education, and I have waxed and waned in my time. We learn techniques and how, when we're caring for a patient, how to protect ourselves. And we have a very close-knit group, as my team is wonderful. So we do a lot of real-time diffusings. We try to just talk it out. We work really closely with our advocacy agencies. So for sexual assaults, it's rape response. And sometimes we debrief together, de-identified, but just really talking about the emotions and things that we might have felt through the process of caring for somebody. It is heavy. Our exam is written in a paper chart. So the paper chart is separate from the electronic medical record. So the details, the nitty-gritty is not accessible to the average person in the healthcare community. We have a whole secure process for our paper charts. And that's where the details are. That's where the details of the injuries and the assault are. And we handwrite that. So you can imagine what scribing somebody's trauma could take a toll on somebody. So we have a lot of stuff in place. We like to do things for ourselves. And I'm an outdoor girl. I don't know if you saw my Jeep, but I do a lot of time outside. I like to overland. I do a lot of hiking. I'm very active with my 2 dogs. I'm a year-round outdoor girl. Lots of winter sports, ice fishing and snowboarding and things like that. So we encourage that of each other. And case reviews, emotional diffusings, self-care. We're big on self-care.
You are listening to Q Point Podcast. I'm Keri Quirk, co-hosting with my husband, David Quirk, and we are having a conversation with Keri Kapaldo, RN, Safe Program Coordinator at St. Joseph Hospital.
And how many people on your staff?
Right now, currently, there's 9 other safe nurses, so 10, including me. I have some that work full-time. I have one that works part-time, and then I got a variation of per diem. Some of them are full-time ED nurses, and they're per diem to the safe department, and some of them are full-time safe nurses and per diem to the ED. Sometimes it's nice coming to work and just taking care of ED patients. That's also a little bit of a break. And then sometimes it's really nice to be able to take a break from the ED patients, and I'm really going to just focus on this one person, because that's like the best part about being a safe nurse. It's what you thought nursing was going to be when you went to school. You get to be one-on-one with a patient and fill the gaps, or at least connect them to the people that can help fill the gaps in their care. It's really selfless, but it feels good.
If someone is unsure about involving law enforcement, what options do they have for receiving care, collecting the evidence, but deciding later that they can move forward? Is that a thing?
Yes, we're lucky. In Maine, there are some states where felony assaults are mandated reports to law enforcement. In Maine, that's not the case. So anybody who presents for medical care for anything other than a gunshot wound, we are not required to report to law enforcement, and their privacy and confidentiality is maintained. So we get to work with them however they want. So if they don't want to involve them, they don't want to release their record, they don't have to. If we're talking about a sexual assault, in Maine, you can have evidence collected and it is stored without your name. We call it an anonymous kit or an unreported kit. For us, it goes to Bangor PD, and they are legally required to keep it on their shelf for 20 years, the statute of limitations to report. So they can change their mind later on or not, and it's just there. So they have an option. If they don't quite know and they're in that evidence collection time frame, they're like, okay, I can do this because I might be able to change my mind later. And that's a really good option for them.
You said you need to learn how to testify in court. If they did decide to move forward, is that something that you would go and testify because you collected the evidence?
Yes, but more about the medical care and findings, or if they had injuries. There's also parts of what they say to us that could be considered medical hearsay, so we could actually testify to what they told us. That's a legal thing, so a little bit beyond me, but we take all the information. For domestic violence, we do quite a bit of testimony around domestic violence patients because they tend to have a lot more injury, especially if they're strangulation patients. I've testified quite a handful of times, both because I was the one that cared for them and as an expert.
So you have a broad base of territory that you're covering.
Yes, we're technically in Bangor and in Penobscot County, but we have people that come far and wide to see us. A lot of the hospitals that surround us in more rural areas don't have access to safe nurses consistently, or they don't have any. And advocacy agencies know that we're there and guaranteed. I think we've been well advertised. Word of mouth has gotten out there. And so sometimes people will just automatically make the trek to us. If advocacy intersects ahead of time and they're talking about going to the hospital, they give them all of their options. If people want to seek care in their home community, I really encourage it. We want that. You should be able to. Technically, any ED nurse or ED physician can perform a sexual assault exam. But I always like to compare that to what I want an ED physician doing open heart surgery on me. No, I probably want a cardiac surgeon doing that. Not that I'm a cardiac surgeon by any means, but what I'm saying is that I have the extra training and I know what things to look for and focus on. More medical. We really try to harp on that there's so much more than just a kit. And I think that's one of the biggest myths. People will come in, they're like, I need a kit done. It's like, okay, no problem. There's so much other stuff I can do for you. Let's talk about medicines. Let's talk about your body. Let's talk about advocacy. You know, what are your plans? Have you eaten today? Stuff like that. Do you need a shower? Little things that add up and we focus on it. And I love that. So when we're talking about rural Maine, we have such a great reputation. People don't have a problem traveling to come see us. Sometimes they will enter their home hospital and then they're given the option to have it done there by an untrained staff member or to be transferred to us, which if we can, if we're not already taking care of somebody, we gladly will help them however we can.
How does your team work with the district attorney's office on evidence, reporting, expert testimony, or case preparation?
We have to get a subpoena. You know, we'll get subpoenaed by the DA's office if they have a case that's going to trial and we've done medical care. They'll get the record and then they'll usually subpoena the team that cared for them. So depending on the county that subpoenas us, usually we'll see the emergency room provider, the physician or the PA, and then the safe nurse. If the safe nurse is new or in training, we might see a second safe nurse that was precepting them get subpoenaed. And then they'll usually, depending on the type of assault, also have an expert come in. I don't typically testify as the expert when my team has done the case because that could be seen as biased and I have a little knowledge of the case in a different manner. but I have given testimony as an expert for other cases before. They also help us with like expert testimony training. So there's various ADAs across the state. So there's 2 experiential testimony trainings that are offered twice a year. And I think they volunteered to help us and do like little mock trials. So that's really great training. When we get a subpoena, we do collaborate with them and we lay out the facts of our case and we go to trial when we have to be there and we show up and we testify. But the same thing if we were subpoenaed by the defense attorney. So if defense ever subpoenaed us for medical records, the same exact process. We would connect with them, we would respond to the subpoena, we would cover the facts of our case, and we would show up to court and testify.
So how many cases do you have in a month?
We average about 2 to 3 cases a week over the span of the year. So some months we have definitely higher volumes than other, and we wax and wane, and I've trended that over time. I can almost guarantee which months we're going to see higher volumes than others. As you can imagine, college being in impacts our sexual assault numbers. So when they're out for the summer, we actually have lower volumes of sexual assault in the summer than we do the end of August and beginning of September is usually high volume. And we have quite a bit of domestic violence in October. We have quite a bit of both in March. All violence across the spectrum usually escalates end of February into March.
And what percentage would you say that drug-related part of the assault?
I don't know if this is causation or correlation because we live in Maine. We live in Penobscot County. I feel like it's hard pressed to find anything that doesn't have substances or alcohol adjacent to the event. But usually somebody was drinking or somebody was partaking either consensually or not consensually. Of course, there are times when people are completely sober and the violence occurs, but I don't know if I can fully correlate it. We're over 160 cases so far for this year, so we're over 3 a week. And if we had ended the year at about 150, that's what we were averaging, 2 to 3 a week. And we're well over that number. This will be our highest volume year yet.
And where does your funding come from?
Our largest funding comes from the St. Joseph Hospital Commit to Community annual fundraiser. I have also written and received grants, small ones here and there. When we first started getting going in 21, I had a couple of small grants to get equipment supplies, little things like that. And then we had a couple of stop grants from the state of Maine to get some of our volume up for staff. And then it's really been the Commit to Community, in which the biggest fundraisers are community sponsors, businesses donating and making a statement that they're showing up for survivors in their community.
And why don't you tell our listeners more about that event?
It's an annual race. So there's a kids obstacle course and a 5K walk and a 5K run and a 10K run. And it's a really unique event because the course is like on-road and off-road trail. It kind of goes all over the neighborhood in Bangor. We've expanded it every year. We've added more stuff so that the whole family can be engaged and involved. You'll see community partners out there and all of our sponsors, especially Quirk. They're our presenting sponsor every year. And we adore them for that because you're really making a huge statement, and especially signing on annually. We're like 6 years in. I think that says a lot about your company and what you guys believe in. But that fundraiser is growing and growing and growing, and it just makes my heart burst because that's people showing up for their own community. And this year we had over 1,000 people show up, register on the day of the event, which is just bewildering to me.
That's incredible. And what month of the year is that every year?
The last Sunday in September, typically.
Your team has been recognized for statewide Safe Leadership Awards in the past. How has that recognition shaped your program, and why don't you tell us about these awards?
Yeah, we have. It's been quite an honor. So the Maine Coalition Against Sexual Assault has an annual award ceremony, and they always award a safe nurse this Safe Award of the Year. And it's a big deal because it's peer nominated, which means that advocates in the field or other safe nurses in the field, they've put in nominations for that. But the biggest part about that award is that the safe nurse has to exhibit like some sort of statewide impact. So it's like more than just in your hospital or even in just your local community, but a statewide impact. A lot of the nurses in our program have received that award over the last 10 years that I've been in it. Up until last year, we had it 3 years running, and I received it. It was the best honor. Katie Roberts, Danielle Coutu. It was great. We had like this little 3-year streak, and we loved it. It's something to strive for, and it's really something to be proud of because the people in this work are recognizing you. That's what makes it important.
And expand on the board certification. What does that mean? And some of your safe nurses are board certified?
Yes. Board certification. So we have 2 different pathways, SANE A for adult adolescent and SANE P for pediatrics. Board certification means that we've demonstrated that we're like the top end of our field, basically. To be able to pass that test, to be able to qualify it, and to have those initials after your name, you're operating at the top level of your niche in nursing. Most of our safes are SANE A, so board certified as sexual assault nurse examiners for adult adolescents. But something that's really spectacular about our team is that there's only 6 board certified pediatric SANEs in our state. And I have 4 of them working on my wonderful team. So that's amazing. It's something to be proud of.
That's incredible.
That's impressive. As a Catholic, I've been to the hospital a few times. My doctor is a doctor at St. Joseph's Hospital. And I know sometimes people have the idea that it's only a Catholic hospital. You must hear that quite a bit.
Yes, a lot of people surprisingly think that you have to be Catholic to be able to get care at St. Joe's. And that's not the case. We take care of everyone. That's the point of our mission. We care for everyone, no matter what you believe in.
You are listening to Q Point Podcast. I'm Corenna Quirk, co-hosting with my husband, David Quirk, and we are having a conversation with Keri Kapaldo, RN, Safe Program Coordinator at St. Joseph Hospital. So it seems that St. Joseph's SAFE program also provides education beyond the hospital walls. What type of training do you offer to law enforcement, schools, EMS, or other community organizations?
We do quite a bit of education and training in the community. When I first started doing this, it was probably like once or twice a year. And now I feel like my calendar is booked. I'm always out in the community doing education and training. Mainly, obviously, it's around topics that we take care of. So it's not fun stuff. Sexual violence, domestic violence, how we medically care for people, human trafficking. Our team is part of the PINQUIS Sex and Labor Trafficking Action Response Team. We're all trained trainers, and we collaborate with the other members of the team. So other MDT partners, advocates, and law enforcement, things like that. And we go into any business, any organization, any place that wants training on human trafficking. And we give this 2-hour training. It's wonderful. It's kind of like a 101, how to identify it and what to do. And it's one of my favorite things to teach on. I love doing that training. So we do that quite a bit. And I have ended up in front of the vast amount of people doing that training that I would never expect that want it. And I always learn from them. We did it for tattoo artists locally. And I learned so much from them about how people often find getting a tattoo cathartic. And they will kind of trauma dump sometimes on the artist. I never really considered that. So all these things, I educate them as much as they educate me when I'm out there giving the training. And then when I'm talking about EMS and law enforcement or things like that, it's really tailored to our intersection, how we work together, things to look out for. So I've trained pretty much all of the local fire and EMS that present to St. Joe's. I usually re-up every couple of years and get back in and do updates and things like that and catch all of the new people. And it's what to do when you respond if somebody's been sexually assaulted and somebody calls 911, what to do if you've responded to domestic violence, what to do if you respond to strangulation, what to do if you respond and you think the situation might be trafficking. How does that look? What should you do? And how to get them to us. That's the key. And how to be confidential and protect them and help make them feel safe. One of the biggest things that's really important for people to know is that you can tell somebody they're safe all day long, but if you don't make them feel safe, your words don't matter. And that's the key. And so we try to really elaborate that you're already a trusted person and seen as somebody who's there to help. You can take that one step further by proving that you care, by sitting down, not being over them, listening to them, and like meeting them where they're at when you're responding. Those are huge. That's the basis of trauma-informed care, and that's what we do. When we talk about trauma-informed care, I always say it's like the roots of being a safe nurse in our education, and that's because we wouldn't be able to do what we do if we didn't do it in collaboration with the patient. They really get to take control back, and that's the key. So they get to decide how much or how little they want to do in that process, and that's really important. And I think another takeaway from this needs to be that if you've been sexually assaulted, coming to the hospital does not automatically mean you have to have evidence collected. That's not a requirement. You can come and get medical care. You can get connected with an advocate. Every sexual assault patient who comes to us after they've been assaulted acutely, they get an advocate at bedside. They get a hospital accompaniment from an advocate from Rape Response Services, and they accompany them through the whole process and then beyond. I can do a lot in those 4 walls, but once you get discharged, that relationship gets kind of terminated unless we have a follow-up. That advocate gets to follow them well beyond. That's huge. And can connect with them in so many different ways because things happen and come up days, weeks, months, years later. That's where advocacy comes in clutch. You can get that. You can get medication to prevent pregnancy and sexually transmitted infections if that's your concern because you were just sexually assaulted and there's a possibility that you could have those things happen to you. We can do all of that and you never have to have evidence collection. I think that's huge. If you want evidence collected, you can do that too. And you don't have to report to law enforcement if you don't want to. And you can do all of it, none of it, some of it. It's kind of like a little a la carte method. But the key is that we meet people where they're at and we do as much or as little as they want. And we make sure that they're going to be okay. I think that another point that's really important when people are coming to get medical care is to know that we're bound by HIPAA and that our encounters with you are confidential. The only caveat to that is if we have to make a mandated report for concern for child abuse or elder abuse, which is state law. But we don't report if you don't give us consent to otherwise.
Before we let you go, looking ahead, are there any improvements or expansions planned for the SAFE program?
We are working on 2 different things that will have a statewide impact that will affect everybody. And I think that's really important. When I had mentioned that we had those barriers with rural healthcare and that we have people coming from hours away, I also thought, how do we mitigate that? And how do we support hospitals in getting some safe nurses in? The training is extensive. It's expensive. We're hard to maintain nurses. I wrote a grant and received an OVW federal grant to basically sponsor nurses at 4 critical access hospitals that are rural. And they're going to intern with us at St. Joe's and become really confident and competent safe nurses that get to go back to their communities and be an option for people locally. Our numbers might go down, but that means people are going to get care in their home community, and that is what was most important to me, and to make sure that hospitals felt supported and that these nurses felt supported. The other thing that we've been working on, I've been working on this for a few years. Maine doesn't have a kit tracking system. Most states in the nation have kit tracking system that tracks a sex crimes kit basically from the time it leaves the crime lab until it comes back to the crime lab. And survivors can log in and see the location of their kit and know what the status is, depending on what the system is that the state's using. We don't have one, and we're the last in the nation to have one. And because of that, we don't know how many kits are sitting on shelves. We don't know what the inventory looks like. We don't have an idea of how many sex crimes kits have been completed in the state in the last 10, 15, 20 years. We piloted, along with all of Penobscot County hospitals and Kennebec County hospitals, in collaboration with MICASA, a kit tracking study. And there's a website that's been made, and we've been tracking along, and we've already uncovered a lot of really great data. And we've been trying to get legislation through. So there's a couple of bills that are coming up in this next round of the second half of this session, LD 549 and LD 1816. And it's to get a kit tracking system instituted statewide. The difference in the bills is that one involves testing reported kits current day forward, and the other one is just to establish the tracking and inventory and to start to track kits present day forward. One of them went all the way through 549 and then was in that stack of bills that got pocket vetoed because it went over the timeline. And then one of them obviously has a bigger footnote. So that's why there's 2 bills going forward. So we'll let appropriations split hairs on what they can fund that bill. But this is 3-4 years trying to get this going. If anybody wants to talk to the legislators, put in a good word for it.
Well, there's a lot of legislators that actually listen to this podcast.
And who's been on the podcast.
Yes.
Both sides.
I feel like everybody I've talked to is like, we want this. We've pushed this through. I know that the Judiciary Committee is very much behind this. They want to see it through. They've been with us every step of the way trying to make this happen.
So is the issue just funding?
I think so. Yeah, like everything else.
Mm-hmm.
Right? We're in
You're in
competition
line
with like a lot of really important things. So.
Sure. What is one way our listeners can support the SAFE program?
Donations are always welcome. They can visit the website. It's stjosephbangor.org. There's a couple of links you'll have to click through to be able to give a gift, and then you can select the SAFE program specifically.
I'll put the direct link right on the episode summary. So just make sure you go to the podcast on any major platform, and I'll have the direct link.
Awesome. Thank you so much.
Keri Kapaldo, RN, SAFE Program Coordinator at St. Joseph Hospital. Thank you so much for joining us.
Thank you. It was a pleasure.
Thank you. You've been listening to Q Point.
Follow us at qpointpodcast.com or on your favorite streaming app.
This is where you can get the news from the people who make the news.
Make sure to join us next time.
We hope you tune in.
Q Point Podcast invites guests and candidates from all parties to join the conversation. The views, information, opinions, and comments expressed during this program do not necessarily represent those of the host, Q Point Podcast, associates, affiliates, and CQRE LLC.
Thanks for being a part of the conversation. Catch every episode at qpointpodcast.com or wherever you stream. Tune in and tell your friends.